things we did it up till now. But before doing that, I want to make sure that the LED is okay, securely fixed in the distal side. Okay, now it's okay. Go caudal again, caudal, left caudal. So we can show all the projection of what we have done right now. And then we go ahead later on to do what we did. So let's go now back from the first images.
Okay.
And we show all. Can you hear me?
Yes, we can hear you.
Okay, excellent. So we show you from the first image, please. First image. From the first image, what we did. And actually, as you can see, there is two guiding catheter. One is Judkins right on. Yes, unfortunately we have a bloody music in the room. Can we decrease the feedback? Okay, just a minute, huh? Okay. Is okay now? Perfect. Excellent. So we basically, first images. So as you can see, we place Judkins right on the right. And this was a guiding catheter because we thought that we might have had some help to do as a retrograde approach. And as you can see, there are quite good collaterals going to the LED that is faintly seen on the mid and distal part. And then, no, you have to go step by step. Okay, and then this is a projection show you that the lesion is actually not so long. It's not clear whether this diagonal is involved before or later, but next images will show us that is clearly that basically there is a small LED. Okay, and we can appreciate. No. If you should move exactly as I tell you, okay?
Hoca dedikten sonra, tamam.
Okay. So, next.
Devam.
And you have to play it. Okay. The caudal. Go back.
Devam edin.
Back.
Geri mi gelin?
Geri gelin.
Buyurun.
Back. Back.
Daha geri.
Okay. Now, as you can see, there is some exactly. Now you can appreciate that basically there is some good place to interpret, I would say, small channels inside this very old occlusion. It's 2 years old occlusion, intra-stent. But I think the main problem is that, as you can see, there are two stents, one in a left main and one into the circumflex. So, and I will show you how did it affect our progression of the Y. So next.
Bir sonraki.
Freddy, do we see some antegrade
You can
flow
appreciate
there?
the stents from this projection, and you can also appreciate that the LED is quite a reasonable good vessel with good septals. Next.
Bir sonraki.
Okay, this is the left anterior oblique projection. It does not help us a lot, but you can see that there is some lesion also to this diagonal vessel, which is reasonable small. Next. Okay, so at this stage we basically placed a microcatheter, as we usually do with these CTO lesions, and you see the two markers of the microcatheter, which are basically 2 centimeter apart, and you see now that I tried to get in with the filter XT. This is a polymeric Y, very soft, which is basically used for septal engagement, but it can be also used for antegrade approach, even in very tortuous lesion, because and a very old occlusion, because you might find a good micro channel or small channels inside the artery. And actually, as you can see next, this Y went through the struts, through the stents into the struts, and the good things of this Y is so floppy that is at the same time is so good that it does not get out from the stent struts, but is so floppy that you can hardly maneuver. Next. So we were able to basically go into a first septal. This is clear that it is a first septal, and we could advance the microcatheter inside the stent. That was really important for us. We had a little bit of fighting, but then we succeed. Also, the guiding catheter was just jumping from outside. Was jumping out from the engagement of the coronary artery. Next. Okay, now this stage you see that the wire is so floppy that it can navigate within the body of the occlusion. And I think this is one of the advantages of this wire into the very chronic whole total occlusion, because this wire is so soft that it will never go out from the strut stents. Next. So we were trying to push it, and as you can see, we had some fighting, but okay, next. Probably you can see in some, exactly, right now you see that there was disengagement from the guiding catheter, because we were able to get through, but this floppy wire is so floppy that it does not allow us to work properly. And you can appreciate that the microcatheter is jumping out from the occlusion. I mean, this wire is so good to get in, but it's so easy to get out. Next. And then we were able to basically cross the body of the occlusion, but still, as you see, how difficult it is to progress. And if you can understand, this is a polymeric wire, so it should go quite easily down the vessel. Next. So we thought that the main reason was the problem of the strut stent at the beginning of the ostial strut stent. And as you can see here, the wire is not progressing any further. Next. And also, there is an disengagement from the guiding catheter from the ostium of the left main. So at that stage, we selected a balloon, 1.0 balloon, so a Falcon CTO lesion balloon, tube marker, and we inflated the struts. I think that stage that was very, very good, because we were able to cross the body of the stents and basically make a dilatation. Next. And we were able, here you can see, probably next. Okay, at this stage we were able to maneuver much better the wire, and the wire you see is going very easily. But of course this wire is so tricky wire, so good, but you need to handle very softly, because it may dissect also distally. Next. And we were able to advance at this stage the Falcon CTO from Invatec down to the stent struts, and we dilated. This comes quite very few dilatation. So if you can go next.
Bir sonraki.
Next. Okay, next. You can hardly see the balloon because the balloon is very small. Then we exchange the balloon with still with an RX 2.0 balloon. Next. And we were able then at this stage to exchange the wire. This was the most important tip and tricks, because you see this wire should be taken out even if it's then down the vessel, because it's a polymeric wire, it can get out very easily. So we exchanged the wire. Next. With a Pro Water Flex, which is basically like the BMW Universal, is from Asai, and it's a very secure wire, it's very floppy at the end. And you can see now that we exchange also the balloon. We inflated the balloon, is a one marker balloon, 2.5, next, 2.0, next. Okay, this was 2.0 balloon. Next. And we made all the dilatation. Next. I think it's not so interesting now. Next. And up to the proximal part. And this stage, basically, our aim was to get the diagonal bifurcation. And at this stage, we made this trick. We basically take out the balloon from the main artery, and we placed another microcatheter, again the same microcatheter with another wire, just to negotiate the diagonal branch. Next. And I think this must be okay. At this stage we were not able to do that, so we thought that the best technique might have been the side branch technique. Well, this is the side branch technique. Is basically you inflate a balloon in the main branch, and sometimes you are able to open up the diagonal, the side ostium of the diagonal. Of course, here the problem is that there is a stent struts, and that can be a little bit more difficult. So in order not to spoil the passage of the wire, we advanced the wire further. As you can see, there are two wires. We made the side branch balloon before the placement of the wire, and this is allow us then to redraw the wire next, and to have the wire then in place next, to basically try to be able to negotiate this diagonal branch. Of course, diagonal branch is coming up from the strut stents, and is not really big vessel, is about 1.5, 1.8 probably, and now we are left there. We are trying to negotiate this diagonal. I think there is no much room. Actually, we are trying now to get what we can do. Actually, I advanced now a microcatheter, and I'm trying to see if I can get through the struts of the stent, but apparently is you can inject now from left now, okay, and you see that the problem of this diagonal, I think, is that is just jailed. The ostium of this diagonal is jailed by the struts of the stent, and of course this wire is a Fielder FC wire, which is very soft at the tip. Is still again a polymeric wire, and this I think is the news of this this approach, which you can use also for chronic total occlusion, not stiff wire, but just very soft polymeric wire. And you can see that now there is almost the possibility for this wire to go inside this diagonal, but unfortunately the reason that does not get through is the fact that basically the struts of the stent are really a problem. And on the other hand, what we can do, we can select, of course, a stiffer wire to try to get inside the struts of the stent. This can be probably a reasonable alternative to what I'm trying to do right now. But of course, if I'm able to get through the diagonal with this wire, this will be much easier for the distal part of the vessel.
Freddy, you did great job so far. I'm sorry, we should continue, and we have a...
Yes, I'll show you what we did. Inflate. In a few minutes, be ready to go back to the
6,
images
8,
where we get...
8, 10.
Okay, deflate. Okay,
Deflated.
Again, inflate. So basically, inflate now. So this is, how long is this balloon?
6,
20.
8, 8, 10.
This is the problem of one marker.
10.
Okay, deflate.
Deflated.
Again, inflate. Okay, so basically we had good luck because we were able to get through the lesion. Okay, deflate. And with this wire, the field FC, let's go back to the image where we left. Okay. Last images. No, before. Before. 5 before.
Lütfen. Bak yukarı. Ha, onu yere.
Okay. Okay. Before, 1.
Bir geri.
Okay, so we left you, you left me in this situation. Actually, I was with the Fielder FC, and you can see this is a very floppy wire, differently from the Fielder XT, but still very floppy at the tip. And of course, still again, I would say a wire which is not really the best wire to get through the struts of the stent with a very ostial lesion of diagonal. But then we were able to navigate into the diagonal because we had, you see, the micro. This is a micro made by Asai. is a stride, and it has got only one mark at the distal tip. You can appreciate the distal tip of the marker just right at the bifurcation. Okay, next. So we were able to get through, and actually the wire is through the vessel. Next. And you see the advantage of having this wire, next, is the fact that you have, of course, a very floppy wire. You can see now that we were able to advance the micro, and then to exchange the wire, next, to the Pro Water Flex. Again, you can see the two wires are exactly the same. These wires are spring, so are very securely placed in the distal side of the vessel. And we did basically a kissing balloon with a 2.0 on the side branch and 3.0 on the left on the LAD. Next. And then we had much dilatation with 2.5 balloon at the mid distal part of LAD. And again, you can see many balloon dilatation going from distal to proximal. And then this is the last dilatation, okay, within the stents, struts, and this 2.5 balloon went very high. Now you can see it, the vessel is okay, but still the side branch is not performing well. So next, we went into the caudal projection. Okay, we had just an idea of the LAD, how it was. It's not a big vessel. It might be probably proximal maybe 275, 3, but the distal side I won't say more than 2.5. Next, and we went into the distal caudal projection to make some more enlargement of the side branch of the diagonal. Next, the patient is getting some chest pain. This is interesting because, of course, this tells us that there is viable myocardium, but we knew already before. Next, but the good thing is that it's reversal, the collateral circulation now. And I'm sure that if we now inject from the right, we're not going to see anything left. Next. And now we are basically, okay, this is the first images. Now we made this dilatation, and we'll show you now how is the situation on this diagonal, and then we might choose the most appropriate technique for this bifurcation. Okay, it seems that the flow is reasonable. Of course, there is small dissection probably there, and I think that I would place a stent into the diagonal. Is Antonio Colombo still there, or has he left?
No, he left. He left.
He left.
Freddie,
okay,
Freddie,
I think that,
let me ask you something.
Who is Gerald there? Okay.
Yeah, I'm not
Yes.
Antonio, but I cannot speak Italian, but maybe English. The question is, there was a taxus in the proximal LAD and it got occluded, which is, even if people don't like taxus, something very unusual. So probably there was a problem in placing the stent not at the right place. Leaving some space untreated, that is often the case, or under expansion. So I think it would be, in this case, even though it's expensive, a good thing to use IVUS to really analyze where the stent is and where the problem was. Regarding the diagonal, I agree that probably you should treat it. It's a large diagonal, put a stent there.
Yes. Yes, that would be very nice if you think so, and we can assess also the stent if it's originating from the ostium of the left main, just to the side of the bifurcation, or as you say, it might be probably placed a little bit further down, but still I think that we need a stent inside the taxus. So, I don't know, I think that from the practical point of view, I would go ahead placing a stent on the diagonal and then a stent onto the LAD, and we might get probably a possible solution to have a sort of Zabo technique, placing a wire on the circumflex just for the right positioning of the stents of the LAD. But I think that basically, well, IVUS could help us, but will probably prolong too much the session, and we are a little bit late. So I don't know. I mean, I will be ready to do it, and I suspect, as you say, that probably the taxus stent is not right at the ostial side, and some space was left right at the proximal ostium of the LAD. That was the reason why it basically closed, because we knew that this closed up after 6 months. After 6 months
Okay.
after procedure. So it might well be that closed exactly as you said because of the wrong positioning of the stent struts.
There is one
still,
thing.
of course, we have.
Freddy, if the stent would have been perfectly placed and it would have been a failure of the stent itself, then the option would be to use a drug-eluting balloon. Because if the stent is there,
yes,
we have done that in stent CTOs. The study is not yet published,
yes.
but hopefully at TCT we will report on PAP-cut balloons in CTOs. So, but problem is here,
Yes.
the missing probably
Yes, well, I
of the
agree
stent.
that. Yes, I agree that it might be a choice to put two drug-eluting balloons, but because I think that the side branch of the diagonal is a little bit affected, I would really like to place a stent there. So probably, I don't know, I'm not completely sure if this is the right candidate for balloon
balloon stent.
drug-eluting balloon.
Stent for the diagonal, balloon for the main. If the stent is correctly placed in the LAD.
We can do that. We can do that. I agree with you. Let's start now to place a stent on the diagonal, and I would choose a Coracto stent, rapamycin stent, 2.5 stents, which is this drug-eluting balloon. Yes, I know. 2.5 Coracto length is about, I would say, 21. Do we have 21?
2,5-21 Coracto.
Or probably 20. Do we have a longer 24? Yeah. Okay, 24. Let's take 24. Let's see if this can go inside this diagonal. And of course, is quite difficult because there is quite a lot of struts there to cross. The first strut is the one on the proximal, and then on the diagonal. But I think we had a good dilatation now, and we might get good success. Are you there?
Yes, we are listening.
We have a problem in opening the most difficult problem of the Coracto stent is to open the pack of the Coracto stent. But if you are able to open the Coracto stent pack, then you are able to place it. So that sometimes is something that might happen. So we have assistance now to open the pack of the Coracto, but still no way. This means that they are very well done.
Freddy, we have to leave for another presentation. We will be back in maybe 50 minutes.
Evet, zamanı iyi kullanmak
Okay, 50
için
minutes you will find hopefully everything.
Hi, Freddy. Are you there?
Water.
Freddy.
Yeni bir şey alabilir miyiz su arkadaşlar?
Hello, Freddy.
Yes. Hello.
Yes.
So what we do now,
Yes.
what we are doing now is exactly the same that Professor Werner was telling us. So we implanted the stent on the diagonal, and I'll show you now. And we we did the kissing balloon at the end of the procedure. And now we are basically thinking, as Professor Werner was telling us, to basically doing the drug-eluting balloon. And for doing that, we first check whether the stent, the Taxus stent, was positioned at the ostium of the LAD. I will show you first the images. Go back. So we implanted, go back. Back, 5 back. 5 back.
Okay.
Go here. Okay. So this is the dilatation. Okay, next. Okay. So this is it before the stent. Next. So we implanted the stent, and you can see this is the mini crush technique that actually I am the pleasure to show you live or almost live. So we positioned the stent on the diagonal, and the stent of the main branch, and on the main branch you have a balloon. So the stent on the side branch is 2.24 correcto stent, 2.5, 24, and the balloon on the main LAD is 15.30. We check next. We check in a different projection, and you see, just to make sure, this is the secret. The marker of the stent should be basically lying on the wire or on the balloon of the main branch. Next, and you check in the three different projections. Next, and the final projection is this one caudal again, so the position is correct. So we implanted the stent. Next, and this is the implantation. You see, the balloon is still there. Next. And it was a very interesting point. You see now the wire onto the diagonal. The wire onto the diagonal is fractured. And this may happen with this polymeric wire, not when you redraw the wire, but when you push it. And this is what happened. So we didn't want to crash the balloon or crash the stents, and so we redraw the wire. You can see that in the black spot of the 3 centimeter wire there is a fracture of the wire. We remove the wire. Next, and then we position it again. You see that the fracture stent inside the guiding catheter, and then we crushed now the stent struts of the diagonal. Then we placed again the wire, and we did the kissing balloon. Next, and you see now the kissing balloon with 2.5 on the corrector stent and 3.015 on the main branch. Next, and this is the final result. Okay, we did more dilatation more on the distal part, and this is the final result. I think it's reasonable, very good. Next, and we'd also have an anteroposterior. Well, okay, forget these images. Okay, next. Okay, this one is clearly shown that the bifurcation is well covered. The stent struts are well open, and I think the kissing balloon was really well performed in this patient. And now what we are doing, following the suggestion of Professor Werner, Gerald Werner, is to check by IBUS if the struts of the taxus previously implanted is just at the ostium of LAD, because if it's like that, we will do a drug-eluting balloon, and if not, we will implant a further stent into the LAD. Any suggestion, any comment from the panel? Keep quiet.
Okay, would you please
Freddy?
how to connect this? Would you please? Okay.
Yes, even in the taxus at the ostium, please let patients have advantage of free DS, and please put it DS, otherwise we cannot put it later on.
Okay, sorry, I did not get your answer again. Can you repeat me?
Okay, so if the taxus is at the ostium, so you plan to do
Yes, if the
drug electric balloon, right? So how would the result?
exactly. If the taxus is at the ostium, we will do drug-eluting balloon. We do not have much experience on that, but we are basically building up our experience in these cases. Actually, I perform no more than 4 or 5 of these cases like that, and I'm trying to follow this patient with angio follow-up at a short period of time, because I'm not completely familiar with the result, what can be. Remember that this is, of course, is a CTO lesion, so probably it's not only wrist stenosis, but it's also a CTO wrist stenosis. Okay, now we have the images right at the ostium, and I don't know if you can see the images, but I tell you that we are, I think, exactly right at the ostium of the side branch. And let's try to make the best to have a very good flushing. Okay, so this is the stent struts you can see now.
I think
and I'm redrawing. Can you see? No, I can't see anything. No, sorry, there was a problem here.
You're in the guiding catheter.
Now we are reaching. No, just a minute. I think I have to do the thing, everything. Okay, now here we are. So I have to look myself too. Unfortunately, I think that okay, we might be able to do that. Okay, now we are inside the stent, and we are now going into the LED, and here the stent struts of the circumflex artery. So you can see, I think, that there is what we thought to be here, right here. You can appreciate it, that there are no struts, and we are right at the ostium of the LED. If we go any further down, we can appreciate the struts of the stent. So we might, you see now, they're now coming up, and you can see that the side branch of the circumflex is gone. So it might well be, if you see the angio right now, it may well be that the stent was not positioned right at the ostium, because you see now there are 1 millimeter probably, and now comes, you see, the stents of the circumflex. So we have the clear idea that there is a missing, you see, in this positioning, we are missing the ostium of LED, which we can see later on down there, you see now. So this means that probably, I think, we need to positioning a stent, and if you all agree on that, of course, drug-eluting balloon is a very good option, but I think that probably considering this problem, as Gerald Werner was telling us, I think it's most appropriate to place a stent right now. What do you think, Omer?
I will ask the audience if it's okay. Sizce balonları bıraksın yoksa stent koysun mu?
The millimeter?
Balon diyenleri kaldırabilir mi?
Correcto, 3.0.
Stent diyenler?
3.0.
Okay. Freddy, audience agree with
yes.
putting stent. I'm sorry. You have to put a stent.
Okay. Now, what I tell you is that we can do the following. We can do a very funny things, which is called the Zabo technique. It's a technique basically that you can do if you like to see. I don't know if there are people around and there is room for live connection. But basically what we do, we just try to positioning the stent right at the ostium of LED. So to make this business, we advance the wire into the circumflex, as you can see now, and now we basically do the following. So we take the stents, which is 3.0 stents 20. I would say 24, because the previous stent was 20. The previous stent was 20.
ACT.
Was the previous stent 20? The previous stent. No, the previous stent, Mustafa. The previous stent was 20.
312.
312?
Yes.
Okay.
Taxes.
324. Okay.
This is George.
Yes.
May I ask this is George.
Hi.
Because we don't understand the strategy of person because we don't is to stand the ostium.
Yeah, I will show you right now. Basically, to make sure that the stent is right at the ostium of LED, where is the stent? We will do the following. We are inflating the first net of the stent, and we are trying to make it passing into the wire which is into the side of the circumflex artery. And this basically will allow us to positioning one struts before the ostial positioning of the LED. I will show you how to do it. Of course, you need.
Zabo tekniğiyle ilgili faktoid var mı acaba? Zekeriya Bey bir sorar mısın?
Okay. So to
Hello,
do that,
Freddy.
you
Freddy,
need
let me ask you something.
Yes.
Because it's great if you demonstrate the Zabo technique, but this is not the issue of demonstrating the Zabo technique. The issue is that if you need really to stand this left main, and in my view, this is a left main that it is not normal. So it's great demonstrated, but can you assure that this would be better if you stand just?
Can you speak louder?
Yes. I was just saying that it is great if you demonstrate the Zabo technique, but the question here is not really demonstrating the Zabo, but if necessary to stent the left main. And the left main seems to be diseased. So in my view,
Well,
in this case, or you had an IVUS there, just check whether the stent left main is diseased or not.
we had the IVUS, no.
Because
we had
to me,
the IVUS,
geographically,
and
this
we
is
don't think,
this is a left main that it is really diseased. Can you show us the IVUS pictures of the left main? Because if in my
okay,
view,
probably George, you were,
I would do a crossover.
you forgot that the stent has already placed a stent. And now this is the follow-up of the left main stent for
Yes.
about 1 year. And it's a bare metal stent that did not show any restenosis. We checked with IVUS, so I think there is no point to implant another stent on the top of that. This is my personal view. Okay, now you,
Main
you,
branch.
you
Okay,
do-
I'm ready.
Okay.
I'm ready. Okay.
okay, what we need to do now, the light, I need the light on here.
Biraz ışık.
Okay, now you need to inflate the stents a little bit. Light here,
Işığı buraya alalım arkadaşlar.
inflate the stents a little bit. Just you need to watch,
Okay,
because you need to watch and
A little bit, okay.
okay, just a
Two
little, just
atmosphere.
okay. As soon as you open up the strut
Two
stent,
atmosphere.
okay.
Two
Look,
atmosphere.
look, I don't see very well.
Okay.
More, 4.
It is now 4.
Okay, stop.
Okay.
Redraw now.
Withdraw.
Okay,
Negative.
you can see now that the strut stents. Ui. So you can see now that the strut stents are open up. Can you see?
Closer, a little bit closer.
Can you see?
No. A little bit closer. No. Okay, I can stop. Okay.
Can you see now?
Not really actually. Not really actually.
Can you focus on this? Produce too much light. Switch off the light. Switch
Yes.
off the light.
Yes. Yes.
Can you see now?
I don't see the wire. Where is the wire? I don't see the wire. Where is the wire?
No, the wire is not there. If I want to show
you just
you
open
only
the strut.
the
Okay,
struts.
okay, okay.
Open the
Okay.
strut. Can you see the open struts
Okay, yes,
or not?
yes, yes, it's clear.
Yes.
Here.
Okay,
Is it clear?
yes.
Okay, now light on.
Light on.
I will get inside the struts of the open up struts the wire onto the, you have to put it because I don't see, inside the first struts. Unfortunately, you need to have the help of a young fellow for this procedure.
First strut.
First struts,
Okay.
yes. Okay?
First strut.
And then now we crush, okay, we crush the struts. You have to tell me if this is okay, because I feel only tactile,
Okay,
but I
let
cannot
me
see anything because my eyes are gone.
It's crushed now.
It's
okay.
crushed. So now we advance both, basically the stents along this wire, and of course with the struts within the, now you have to make sure that the two wires are separating. Okay, this is the diagonal, remember.
Yes.
Remember.
This one is diagonal. Okay.
Okay, remember.
I'm holding it.
Because now they will come both.
Okay.
Okay, and this is LED.
Okay.
So remember, LED is here.
Yes.
Don't
yes.
move.
Okay. Okay.
Okay, Mustafa is very well trained. It was really very good procedure working with Mustafa, and of course it's a demanding procedure, but we were lucky to do it. And now, usually this procedure, the Zabur technique, this is LED, right?
Yes.
Is not so easy when you have instant restenosis, especially if CTO, because of course you see now what's the problem,
İbrahim Bey hareket
that you
etmeyin.
might get some trouble from the tube wiring, and this is a nice clear demonstration that you might get some trouble, and probably this is because of the struts of the previous stents. So this is something that we tried. If not, we of course we remove the wire gelled. But I think right now is not a problem of the struts, but is, I think, more than a problem of the stent on the left main. Okay. And now comes the more difficult part, because of course now we need to
Anjiyo görüntüsü görebilir miyiz?
and unfortunately you see the strut stents are not allowing me to get inside. So at this stage is not the problem of the Szabo technique, is the problem that we need probably to make a little bit more room.
İbrahim Bey çok oynamayın, hareket etmeyin.
You see, we have the possibility, but unfortunately is not getting through. So this is not the reason why of the problem of the Szabo, but it's the problem of the, of course, of the stents in the LED on the main, and also the big curve that is making the. So I suspect that we might get a different alternative solution, which is the one to redraw the wire, the stents, to make some more room with a bigger balloon, and then to redo the same procedure.
Fred, you need to go up.
Stent, we dilated more the struts of the stent. We implanted the stent, and we are doing now the kissing balloon. Take a new one, trio.
Okay, okay.
And then we are. Let's go back. Let's go back. Oh, go back. Okay, before. Okay, this is the placement of the stents. We didn't do Szabo anymore because we thought that might have been probably a problem into the progression of the wire. And we next we implanted the stent. Next. Okay, and this is the results. Now, of course, there is some proliferation to the left main, but I think I wouldn't be really surprised that this is not really a lot. And as we saw with the IUS, so I would really try to fix this bifurcation and get rid of the problem. And of course, this patient might also go a drug-eluting balloon on the left main if there is any need, and this can be done also probably in 3 months' time. So I wouldn't really bother a lot about this left main, because it's been there for a while. Okay, small injection. Okay, perfect. So let's go first diagonal.
This is the main?
Diagonal.
Okay.
Okay, go. So we do the kissing because we haven't done the kissing.
I'm going.
Of course, we did the
2 atmosphere.
the
4
kissing
atmosphere,
before.
6, 8,
Okay.
10, 12.
Okay, we don't see anything because I don't know why. I don't know what's happening here. Sounds very strange to me. Okay, we are working now for the last okay, 2 hours, and probably we are doing some okay, try to again go.
Go, I'm going now.
Yes, go.
Inflating. 6
Okay.
atmosphere. 8.
Okay, now
10.
it's okay.
10 is enough or 12?
No, 12.
Okay, 12. It's 12 now.
Okay, so we finished right now, and I think I want to show you the final result. And of course, this patient might go a drug-eluting balloon on the left main in a short period of time. This is a patient, by the way, young patient that needs to be followed with functional imaging and also angiographic follow-up. He's a CTO, so of course, in addition to the left main, he has CTO lesion, so I need to be followed carefully. And further to that is a young patient. So I think, and he's also symptomatic. During the procedure, the patient was symptomatic, but now, of course, he's free of symptoms. And I think we can get rid of all wires and have a just last check. Okay, and we do this first this projection. Okay, then let's go now cranial. Okay, the standard procedure, the standard projection we did before. Excellent. Okay, that was very good. And all you agree that I think we achieved a very satisfactory results.
Excellent
of course,
result. Thank you very
LAD's
much.
disease distally.
Thank you very much.
Okay. Thank you very much to you and to everybody here, which were very patient despite we were really in a hurry. Thank you very much.
Thank you. Thank you. Diğer salona geçebilir miyiz?